Welcome everybody to today's webinar, an introduction to economic modeling in the context of the HTA. We're excited to have a number of great speakers here with us today, but before we begin, I wanted to note that there will be an opportunity for questions and answers later. Please use the chat to ask your questions or share comments during the presentations. Also, if you have any feedback after today's event, please email us at covidend@mcmaster.ca. Our speakers today are joining us from the School of Population and Public Health at UBC. I'd like to welcome Craig Minton, Tanya Conte, Pardis Alaxade, and Gavin Wong. But before I pass it over to them, I'd like to share a brief introduction to Covidend. So as you can see here, Covidend is a time-limited network that has come together in response to the COVID-19 pandemic to help in a number of ways, to help those supporting decision-making about COVID-19 to find and use the best available scientific evidence, and to help researchers to avoid waste by reducing duplication in and better coordinating COVID-19 evidence syntheses, technology assessments, and guidelines. Covidend's partners include 50 plus of the world's leading evidence synthesis, technology assessment, and guideline groups. You can see just some of the logos of our many partners here. So if you'd like to know more about Covidend, I'd encourage you to visit our website. In particular on there, there's some pages with an inventory of best evidence syntheses for public health measures, clinical management, health systems arrangements, and economic and social responses. There are horizon scans for emerging issues, and there's a community of those supporting decision-making that you can get engaged with as well. You can also, as I mentioned before, email us at covid-end@mcmaster.ca or follow us on Twitter at covid_e_n_d for Covidend. And that is it. So with that, one last acknowledgement just in terms of funding for Covidend. We'd like to acknowledge funding from the Government of Ontario, National Institutes of Health Research, as well as individual donors through the Center for Effective Altruism and Fidelity, Charitable, USA, and private individual donors, as well as the Canadian Institutes of Health Research. So with that, I will pass it over to Craig and his team to share their presentation.
Great, thank you very much, Stephen, and good morning from the West Coast. Good afternoon for those of you east. Just let me put this into presentation mode. Can I get a thumbs up? Can everyone see those slides? Yep, great. So as Stephen said, we're at UBC in the School of Population and Public Health and the Center for Clinical Epidemiology and Evaluation. And we are also coming to you from the traditional and unceded grounds of the Musqueam, Tsleil-Waututh, and Coast Salish peoples. And it is our great pleasure to talk to you guys today to give an introduction to economic modeling in the context of health technology assessment. What our plan was for the session was to just give a very brief overview of modeling in HTA and how they intersect. And then once that is done from me, I'll turn it over to Tanya, who's going to provide some context for how the health technology assessment process in BC works, and at least the HTA process that we're involved in with the BC Ministry of Health. And then Pardis is going to run us through modeling, economic modeling, and some basic steps around that. Our fourth speaker, Gavin, who I don't think has joined the call yet, was going to talk about evidence synthesis and the evidence behind the modeling activity. But if he doesn't turn up, we will cover those slides, and then we'll just provide some overview and summary. Talk a little bit about how this work is important and what kind of impact that we see out of this work as we partner with the BC Ministry and the health authorities here in BC. So in terms of modeling and health technology assessment, so in most cases, clinical and economic evidence must be either transferred from one study population to another or combined and linked in some way. And so That's a way of saying we don't have primary empirical studies for every question that health authorities, ministries, decision makers in the health system are trying to address. And as such, modeling becomes an important option to help inform decisions around funding and or stopping funding of certain technology services treatments. Now, where does HTA come into modeling, and how does this intersect? So decision makers obviously need to balance costs and consequences of adopting or discarding technologies based on available data. And HTA then is understood, seen as, health technology assessment is seen as a process to evaluate the social, economic, organizational, and ethical issues of a given health intervention or technology. And I think sometimes people think about HTA as just looking at technology in a very narrow or strict sense, but really it's meant to be any intervention, program, service, diagnostic, treatment. So there's a bit of a misnomer when we refer to health technology assessment. Think of it very broadly as a tool for assessing interventions, programs, services. And the key part here to say, and this will come up a little bit later as well, but that modeling is just one part of the HTA process, and modeling is the part that we were asked to speak on today. But that if you think about a broad set of criteria, social criteria, economic criteria, organizational criteria, ethical criteria, the economic modeling is going to be one part of that, an important part, but it's not the whole of it. So in some contexts, economic evaluation and HTA are synonymous, and that's not how we view it at all. In fact, I don't think that's being true to what HTA is. And so we have an HTA process. We have one component of that being decision analytic modeling. And we recognize fully within that there are other aspects to the HTA process, which Tanya will touch on in a couple of minutes. So I just wanted to also distinguish the economic modeling that we are talking about today from what has been probably the most common modeling that has been in the news over the last 18 months, and that's modeling for infectious disease. And I just wanted to distinguish this because they are two different beasts, and we are not talking about epidemiological modeling today, but to just distinguish them, there are two main types of modeling in infectious disease, deterministic and stochastic. Like any model, the modeling that we see around COVID is, based on assumptions around effectiveness of a given intervention, and thus validity is only as good as those assumptions. That is also the case in the economic modeling that we'll be talking about. This kind of epidemiological modeling provides information as to which interventions to implement for how long. You can think of all the public health measures that are being introduced alongside of the modeling that's being done. And as we do see with the COVID modeling, these models are updated regularly and can be an important part of the information base for public health responses. So just wanted to kind of put that out there, but then really park that and then shift back to where we want to go with the talk today, focusing on HTA and economic modeling. So Tanya, over to you to run us through the BC process, and then over to Pardis after that to talk through in some detail about economic modeling.
Thank you, Craig. Can you guys hear me?
Yeah.
Okay. So I'll just give a little bit of a context in the BC healthcare system, how the HTA happens. So in BC, there's a committee called HTA, Health Technology Assessment Committee, which has a process to analyze or assess new technologies, but also existing technologies to make recommendations with regard to investment and disinvestment within the BC healthcare context. This committee has a prioritization of topics every year where they choose the most relevant ones for this health system. This committee is composed of 8 to 10 members of an advisory council that comes from different health authorities, 2 public members and 5 secretariat members to give admin support for this committee. The committee set a defined set of criteria which they use to score the technologies against in a multi-criteria decision analysis process. And it includes from condition severity, the evidence of effectiveness on health and non-health benefits, ethical considerations, whether the technologies affect underserved populations of interest for BC, whether there is already evidence of cost effectiveness in the published literature, or do we need to produce one primarily for the BC context, environmental impacts of the implementation of the technology, implementation issues that might be faced through this healthcare system as they differ across Canada or across the world. And they also do a basic risk assessment, what are the risks of implementation of the technology. Once HTA report addresses all these components of this criteria in a report, they go back to this HTA committee, which scores the technology, make recommendations that goes through other committees like health services, finance, corporate issues, and after that goes to the leadership council to define the policy around the recommendations. Once the final decision is made based on this assessment and the scoring criteria, then there's a policy communique that's signed. Confidential information might be redacted if there is any included in the report, and then the HTA published the HTA report and the policy final decision made around that technology. Currently in BC, there are 3 groups that produce HTA reports for this committee, and C2E2 is one of them. And we tried, this process has tried to be contained within 4 to 6 months for each technology for the assessment, but obviously they vary according to the scope of work, the complexity of the issue, how many research questions or technologies need to be assessed for a certain decision problem. Next slide, Craig. So as you can see, all these many different components that addresses that set of criteria serve as the input for us to build a decision analytic model, which is this big engine that tries to make sense in a sensible way of all these different inputs. And the product of this decision analytic model is a BC economic specific evaluation and an estimate of the budget impact for the different implementation scenarios of the technology, usually for the next 10 years, for different implementation scenarios or decisions that might be made with regards to that technology. This process is not linear, and parties are going to talk more about the process. But like I said, faces 2 main constraints, which is time and funding to fund this assessment. Like how fast we need to produce this big engine, and how much funding is there to put into this work. And then that's how we try to shape the scope of work facing these 2 main constraints. Next slide. So a decision analytic model is nothing more than a mathematical model that uses mathematical relationships to define and compare a series of expected consequences that would result from a set of interventions or a set of decision problems or options that's being evaluated with regards to those technologies. And this mathematical model tries to synthesize information from multiple sources to make sense of all these different inputs. The most common simulation techniques used for non-drug technology that we use in the HTA is usually discrete event simulations, Markov Monte Carlo simulations, micro simulations, and sometimes hybrid models that can use these different techniques in the different portions of the model. And the goal is to identify interventions or decisions that produce the greatest healthcare benefit with the resource available for that context. Like Craig already mentioned, it's not a complete procedure for determining resource allocation decisions, as the model cannot incorporate all the values from that set of criteria into this big engine. So the only things that can go into this model is anything that can be represented by a mathematical relationship. So for example, ethical issues might not be be possible to be incorporated. And that's why this committee has this other set of criteria that gets scored against in a more qualitative way. Next slide. So a decision analytic model can be understood as the aid to complex decision-making process that provides a framework to compile clinical and economic evidence in a systematic fashion, in a sensible way to reflect the context where the decision needs to be made. And it's an alternative to trial-based economic evaluations. It's widely used, especially in situations where there is not, like Craig mentioned, there's not a single trial reflecting that healthcare context for every decision problem you face in healthcare. It's also used when a single trial, you might even have a trial that has a cost effectiveness analysis, but doesn't reflect the context where you need to transfer that decision. Or a single trial does not capture all the outcomes of interest for your healthcare context, or is not conducted over a longer time period that's sufficient to capture differences in economic outcomes. And that's where economic models come in place to make simulations and extrapolations from the existing evidence to longer periods of time or to different what-if scenarios. Also to not relying on one single trial data and not be ignoring other sources of information like other trials or meta-analysis or other studies that are relevant to the context. And then you can produce sensitivity analysis and other scenario analysis to simulate this other what-if options and how to deal with this technology. Back to Paradis now to talk a little bit more about the process.
Okay, can you hear me? So thanks, Tanya. So over the next few slides, I will provide an overview of our process and how we take these different HTA components to help us design a decision analytic model with the ultimate aim of informing the policy question that's under evaluation. So one of the first step that we take as modelers is to really gain a very solid understanding of what the decision problem actually is. And that's really very closely aligned with the policy problem. And this step really helps the modeler have a solid understanding of what the scope of work is and what the important considerations are that are relevant to the specific policy question that's under evaluation. So specifically in this phase of our work, we try to really understand and define the target population that needs to be evaluated within the decision analytic framework. We also take a close look at the local context in which this technology will be used in, and as well define what the appropriate comparator would be given the intervention that's under evaluation. In this phase of the work, we actually also conduct early stakeholder engagement to identify relevant institutions that are important to the decision-making process to ensure that their important factors are considered and reflected within the decision analytic model as well where appropriate. Next slide, please. So once the decision problem is well defined, the next step of our work is to define the model boundaries. And in this phase of the work, really it's really an acknowledgement that models are simplifications of reality. So we really have to work to specify outcomes that can be modeled with within the model, within the decision analytic framework. And this process is really highly aligned with the availability and the quality of clinical evidence that we have at hand to inform the treatment effect for the technology that's under evaluation. Next slide, please. So once the model boundaries are defined, we move on to design the actual structure of the model and determine the choice of simulation technique. And in this process, what the modeler really tries to reflect the underlying biological and clinical processes within the model structure. And the advantage of designing models in this manner is that it aligns very nicely with how the disease process is defined and understood, and more importantly, how the clinical evidence is collected which is very important in what we use to inform the actual transitions within the model. Now, given this, 4 key questions are considered when deciding on the choice of simulation technique and the ultimate model structure design. And that is whether or not the disease is chronic or acute, whether the risk of the clinical event actually changes over time or does it remain constant, and that actually translates to the treatment effect component as well. And another important consideration is to decide whether or not patient history matters in this context. So do we need to account past events for the patient, and does that affect the ultimate outcome for the model? Lastly, we take a close look at how that specific clinical condition has been modeled before, and that's typically done through a review of the previously published literature on this specific topic. Okay, thank you. Next slide, please. And this slide is really here to demonstrate that the model within this type of work that we get, the model structure could really vary greatly depending on the clinical condition and the scope of work that we are looking at. So on the left, you can see that the structure of the model could be quite complex or quite simple. So we really, within our work, we work with a variety of complexities. Okay. Next slide, please. Okay, so the next stage in this process, once we have sort of honed in on the model structure, the next step and a very important part of our process is to parameterize the model. And that's really to bring together all of the relevant evidence that we need to inform the model structure that has been designed. Now, this is done in a systematic way. So all the evidence is identified systematically. And Gavin, following me, Gavin will provide you with a more detailed overview of how the clinical evidence is identified and interpreted. But in terms of the costing components, this process is really informed by what the ultimate need of the decision makers actually are. So the level of detail that we consider in terms of the costing really helps to ultimately inform the decision maker and possibly down the road the implementation considerations. So if detailed costs are required, micro-costing approach is undertaken. But in cases where that's not required, a higher level costs are incorporated within the model structure. But this is always a consideration that's thought about throughout the process of developing the model. So this needs to be considered early on as well. Okay, next slide, please. Okay, so lastly, I think last consideration in this process is really an acknowledgement that uncertainty is present in all economic evaluations. And as the modeler, as we think about sort of the decision problem and all of the different components, especially the sort of model parameters that we collect, this is something that's always in the back of our minds. And where appropriate, we apply the relevant methods to quantify the degree of uncertainty. And I think the most common approach that we undertake for this is to create probabilistic models. And what that allows us to do is to address parameter and decision uncertainty, which helps us to quantify the degree of uncertainty that is present within the outputs of the model. Okay, next slide, please. Now, within once sort of that process is complete, so we have completed and built the model infrastructure, parameterized it. What we are left with is the results that we can present to the decision maker to decide whether or not the new technology provides value for money. However, that infrastructure is really can be used to conduct additional analyses that could help inform the decision-making process. And one of those, as Tanya mentioned previously, which is done routinely within our work, is to conduct a budget impact analysis. So really use our platform that we have developed to determine what the budget impact of adopting this new technology is. And less commonly employed, but a possibility within the platform that has been developed is to assess whether it's cost effective to invest in more research given the specific policy problem that's under evaluation. So that's really, is it, if there's a high degree of uncertainty associated with the output of the model, is it worth to invest in more research to reduce this uncertainty? Okay, and I think with that, I'll pass it over to Gavin, where he can provide you with an overview of our process for identifying clinical evidence that's used within our model. Thank you.
Thank you, Patty. As Tanya has mentioned, the BC HTA process has independent components of evaluating clinical evidence with the regular process like the search, the analysis, and then the critical appraisal. But what we are talking today is how that clinical evaluation part can help the modeling that to make some important decision for the model. So the first question in this process is that the quality of the evidence, that is the parameters that goes into the model, has a great deal of influence of the quality that's of the output of the model. So if we have low quality input to the model, then the quality of the output of the model can be also very low too. So it's very important that in the clinical evaluation process that we identify the highest quality of evidence that we can give to the modelers to put into the model. So we will talk very briefly our process of how we are doing that. Next slide, please. So the first process, we use the care pathway. Care pathway it looks like a flow chart. It is a flow chart that represents the journey of a patient in their disease process and their treatment pathway. So there are a few things that is relevant in the care pathway to this context. The first is that it identified where the intervention of interest is placed in the journey of the patient. So an intervention that is placed early in the journey of the treatment can be looked at very differently to compared to an intervention that is in a later stage of the disease. Secondly, the care pathway also identifies outcomes that will have an impact on the future of the patient, and that is the outcome that we're mostly interested. And the reason that we are interested in the outcome is that the model is trying to predict what might happen in the future for the patient or for the cohort of patient. And so that the outcome that acts as a parameter that goes into the model will have to have some prediction capability too. For example, if we are trying to predict the future of a patient with high blood pressure, although there might be a lot of trial examining how much intervention, say how much medication can lower blood pressure in terms of millimeters of mercury, compared to that, the probability that the medication will have in terms of the probability of cardiovascular event in the future might have more prediction capability than the millimeters of mercury that the medication can lower blood pressure. Secondly, is the duration of observation. So since the model will have to predict the future to a certain period of time, if we only say, if we want to predict the future for about 10 years, but all we have is a 3-month data, then it also affects the quality of the extrapolation of the model. So we have to take this into account when we extract the data from the clinical evaluation and to inform the modeler about the nature of that outcome. So we go by hierarchy of evidence. So the highest level of evidence is systematic review of randomized control trial. If we can have that, that is fantastic. We evaluate the systematic review with tools, and one of the common tools that we use is MSTAR2. If we don't have systematic review, we will then go down to RCT. There could be multiple RCTs that we can do meta-analysis ourselves if no systematic review is found to be suitable for the model. We also evaluate the quality of RCT using Cochrane Risk of Bias 2.0. And if no RCT is available, then we move down to observational studies. And if when there is no observational studies available, then we will have to use expert opinion in that case. But as we move down the hierarchy, the quality of evidence is decreasing. And it is important for the modeler to know that the quality of evidence are there and where does it lie in this hierarchy too, as they can consider when they are modeling. Next slide, please. So in summary, so building an economic model, it is important to consider all these as the quality of evidence that goes into the model. We use the care pathway to identify important outcomes that will predict the trajectory of the patient. And the quality of evidence and the risk of bias is important in, for example, it's important when the model is planning their analysis, for example, sensitivity analysis, because if we have a robust evidence compared to evidence that has a lot of uncertainty, the analysis that a model will run can be very different when there are different level of quality. So the modeler will have to take that into consideration, and only the clinical reviewer can tell the modeler about that. And so as a clinical reviewer, it's our responsibility to tell the modeler about these important parameters. So I will give it back to Audis for the next slide.
Thanks, Gavin. So this is just, I just wanted to briefly touch on our process for reviewing economic models. So within our work, we don't do a formal critical appraisal of the models, but we do, I think, in a way, we do informally do that. I think one of the sort of good guidelines to follow is sort of what's been cited on this slide. And important considerations in this process as we sort of review a model is to look at the specific data inputs that were used. So looking at sort of the high level themes that Gavin just touched on. So the quality of the evidence, the process that was used to transform. So were appropriate statistical methods used to incorporate them within the model. Next is to look at the model structure and whether it's appropriate given the sort of the target population and the research question and the context that the decision problem is sort of the decision problem that we're trying to inform. And lastly is to look at the internal and external consistency of the model. And this component of the work is really only relevant if you have access to review the model itself and assess for validation of the inputs that's used. So for instance, are we seeing for the intermediate outcomes such as mortality, is the model producing the results that we would expect to see within a population that we're looking at? So that's only the internal and external consistency could be assessed when we actually have access to the model itself. And the last one I just would like to make is, I think one of the most common questions we get is whether or not the CHEERS checklist is a critical appraisal tool. And I just want to highlight that it is not a critical appraisal tool. It only is a reporting guideline. So are the relevant information reported within the modeling report, but it is not a critical appraisal tool. Okay, thanks. I'll pass it over to Greg for closing remarks.
Great, thank you. And if you suddenly hear a little bit of music in the background from my end, it's because my 12-year-old has just sat down at the piano. So that will be our closing set of theme songs here. Summary and impact, economic modeling, it is an important part of the HTA process. And as we tried to indicate, the HTA process ideally has a broad set of social and economic criteria. And Tanya pointed out a number of the criteria that the BC ministry anyways has adopted in its assessment of technology services treatments in the investment adoption process and or the disinvestment or deleting process, for which HTA can speak to both of. And then modeling, the one slide that Pardis put up, which had a very simple model on the right side versus a highly complex model on the left side, indicates that indeed the range of sophistication can vary quite dramatically depending on how many parameters we're including in the modeling. In most cases, the modeling will require specialized expertise, and that's the plug to call your local health economist as you endeavor into this type of activity. We find that one of the most challenging aspects to our HTA work is defining that clinical pathway. And I think this probably holds in most provinces in Canada, where there's rarely one single way to be doing the treatment or service at hand that is under evaluation. And that's challenging because, as both Pardis and Gavin referred to, the clinical pathway is really the starting point. And if there isn't a clear single clinical pathway, we're having to, we will have all kinds of challenges around what's the baseline and what is the comparator that we're evaluating something new against. And in that, then it's really helpful to work with the clinical stakeholders in particular early on, and with regular check-ins with those clinical stakeholders to ensure that the clinical pathway is that's been developed is robust and would hold. Obviously, if you're in a context where there's different clinicians with different views on what that clinical pathway is, it can be challenging to navigate those waters. And then as well, the other key stakeholder that we didn't talk much about in today's talk, with our focus more on the economic model, but is obviously the patient and public stakeholders. And our HTA process that we do involves patient engagement directly. As well, we incorporate broader public views in the work that we do. And we think that's a bit of a best model for HTA work, and certainly is piggybacking on what CADIF does as well in those respects. As Gavin pointed us to, the modeling does require sound evidence base. The garbage in, garbage out applies. We find with a 4 to 6 month cycle in these HTAs, including jurisdictional scan, including patient and public engagement, including the economic and clinical review, and then the modeling activity, and on both the cost effectiveness analysis and the budget impact analysis, project management is paramount. You just can't do this kind of activity with the many layers of this activity without really sound project management. And that's my opportunity to just introduce the other member on the screen, Megan Donaldson, who's our research manager and who oversees all of this work. keeps us to task on the individual aspects of the HTA, including the modeling activity that we do. And then, where does this all go? And the one slide that Tanya had, which referred to Leadership Council. So in BC, the structure is simply that the Deputy Minister of Health and the CEOs of the 6 health authorities meet following the Health Technology Assessment Committee's assessment of the work that we've submitted to the ministry. And they come up with system-wide decisions around, again, either adoption or disinvestment of the given technology under evaluation. And I know our team finds that very rewarding, that we're not just writing these reports and then they're shelved somewhere. They're used directly in the decision-making process, so that there's high level of personal satisfaction that we have as a team in that. And then as well, to the BC Ministry's credit, they put all of the work up on their website, so you can access. Usually there's a delay, but you can access all of the work that's being done around this. And then that's a really good thing too. We've talked a fair bit with Cadith and other HTA producers around sharing of models, sharing of these things. Canada on the grand scheme is a small country. In most cases, the province to province comparisons can hold. And so having a public portal where other groups can see what is happening in a given province, and then approaching analytic teams like ourselves to share models and work together across provinces is an important aspect of not only public transparency, but, as I say, for sharing from an academic perspective as well. So that's all that we had to say on this. I see that there's a number of chats, but I haven't checked that. So we're happy to entertain any questions, comments, thoughts. Stephen, do you want to jump in at this point while I catch up on what's going on in the chat?
Yeah, for sure. Well, as you say, there's a number of questions in there, but we'll maybe just start with the first one from John. And I don't know who the best person to answer it is, but he has 3 focused methods related questions. So the first is, why not use Robbins 1 for the observational studies? The second part is, can you elaborate on your approach to eliciting expert opinion? And the third part is, why do you think we don't have a critical appraisal tool? Cheers seems like a good starting point for one. He has some other bigger picture questions later, but those might as well address those methods related questions first.
Great, thanks, Stephen. Tanya Preddy-Scavin, who wants to jump in on the Robbins 1, the expert opinion, and the cheers?
I think Gavin is more appropriate to talk about the Robin.
I think I can and I think I can address maybe question number 1. I have come across Robbins 1 in one of my other research projects. I think Robbins has somewhat of a learning curve, but it is one of my interests. The reason that we haven't used it in the HTA process yet is due to a lack of opportunity, because the recent HTA that we didn't have to go to observational study. All of them has RCT, so we didn't have an opportunity to evaluate critically appraised observational study yet, but it's certainly an interest of mine to use in the future. I think Tanya might be able to address question 2.
Yeah, I posted in the chat now there's not really a consensus on what tool to use to assess economic studies. ISPER has a list of suggestions, and Cheers, it is a good start, but just to be mindful, Cheers is the quality of the reporting of the economic studies. So it depends what type of economic studies you're also evaluating. There are trial-based, model-based, you need to be mindful what you're trying to assess. Obviously, study articles that do not even report transparently on those set of criteria that Cheers listed, if they are not transparent even in the reporting, you could doubt on the quality of the model design and built. If you are evaluating model-based studies, the most common use is the Phillips checklist, which was in one of our slides. but I posted a list of the tools that you can use to do some starting critically, then appraise and think how the model is being presented. But officially, the cheers is more towards the quality of the reporting of the model. The other question, the number 2, can you elaborate on how your approach to listing expert opinion? So usually in this HTA process, we form from the very beginning an advisory panel with the experts in that clinical area with the clinical disease to support us when we don't find data to support the input parameters in the model. Then we reach out to them. And often, if they are not comfortable in giving an opinion when there's no data, we can use also admin data to look at some certain patterns, or they snowball to other experts that they know in their network that can inform that missing input parameter more often. But that's how we use in our process. Yeah.
Great, thanks. And then some broader questions were that is it fair to say that modeling for health technologies, along with modeling about climate change, the economy, and infectious diseases, are more advanced than modeling in other domains? One of your fellow HTA modeling colleagues suggested that this may be because there are these are domains where there's so much at stake. Second, would modeling for health technologies be an exemplar among those 4 and how it leverages evidence syntheses and attempts to use systematic and transparent processes for eliciting expert opinion and an opportunity for modeling communities to learn from? And third, do you think there are lessons to be learned in the health technology space from the very future-oriented modeling of climate change?
Thanks, John. Those are tricky ones. Pardis or Tanya, do you have thoughts on where we are situated relative to some of the other processes?
No, I don't have any point of comparison with other sciences, like other, I don't know, other fields of work. But I assume that healthcare, and it's one of the biggest business, like what's the budget that we move across with our healthcare system? It's a lot of money involved in itself. And I think that's why there's a lot of interest. And even the transparency according, like how we model the forms of standardization, and trying to be more transparent in creating this guidelines and creating standardizations of how to model, how to inform model results, to be able to share models and increase transparency. This is also new within our field. So I would say in the last 10 years or 5 years, that has this movement of trying to let's be more transparent, let's create standards and how to report. That's how the cheers came up. So we can trust each other's models. And I definitely think the other industries can learn from this.
I think there might be a paper in that, to be honest, because it would be a great thing to explore more, and to look at what specific techniques other industries and other sectors are using, and what we can learn and what we can offer. So great points to take away.
Great, thanks. And from Peter, we had a question asking whether all the groups that conduct HTAs for the Ministry of Health use the approach that you've outlined, or whether they use something else. And if it's different, then why, and how does that affect the quality of the product?
Yeah, thanks, Peter, for that. All the 3 groups that the BC Ministry contracts with does use the same process that we've outlined. Our group really has worked the most closely with the ministry around defining these steps, and we spent countless hours, to be honest, trying to come up with a really robust process for the BC Ministry. And then our colleagues in Calgary actually have worked very closely with us as well in the implementation of these steps. Calgary is the second group that works for the BC Ministry, and the third group, IHE in Edmonton, has just come on in the last few months to provide services to the BC Ministry as well. And so they're newer to the space, but the short answer is yes, all 3 groups are using the same steps and the same process.
Great, thanks. So we have a couple of questions next that are related to tools. So Katya asked, what is the tool to assess the quality of an economic evaluation? And Aurelio asked about tools for HTA studies assessment. I said that there are many tools like QHES, Quality of Health Economic Studies Checklist. Do you not indicate them?
I don't know if you want to talk about. I posted a list of tools that can be used. Like I said, there's no consensus. It's for like to have this list of suggestions. I think in our context, depends on why are you doing the review of the economic studies. We do in the HTA process here, the review of economic studies to learn how they model that disease context before. Can models be ever used? What was the findings in the economic evaluation for those? But we are not critically appraising if their tool, like if their modeling technique was appropriate, going down deep into their model. So I think you need to think about why are you doing this review of the economic studies. For us, we just get a context what the size of the problem is. Is it old? It's being highly studied. It's being already shown to be cost effective everywhere, or is this new and we need to start thinking from scratch how to build a model for this context. So I think you need to think through what is the goal of your assessment and then pick the tool that suits your review.
Great. And go ahead.
Okay, I just want to add to that. And I think although we don't conduct that formal critical appraisal as sort of economic modelers, as we are reviewing those models, we do have those critical appraisal sort of categories in mind that was mentioned. So we do consider the data that was input into the model, the structure of the model, and consistency where we have access to it, just in our interpretation of the results and the overall approach that was used within the model. But I think part of the reason that we don't do that is just because of the nature of the reviews that we do. They are rapid HTAs, and oftentimes we don't have time to conduct a full critical appraisal of all the models identified as well.
Great, thanks. And thanks, Tanya, for sharing the list of tools in the chat. From Andrea, she asks, or she said that the JBI has guidance on doing reviews of economic studies. Are you aware of other guidance on this? And what guidance do you recommend to do a review of economic studies?
Yeah, I'm not aware of this, the guidance. And we, like I already said, the nature of our review is just to get a context. So I only have this list of tools that I shared that can be chosen according to what the objective of your review. But yeah, I'm not aware of any other guidance.
Okay. Sinead asked whether the slides will be made available. So yes. So after the presentation, if you can just send me the final version of the slides, I'll make sure that we post them on the COVIDN site and can share them through our Twitter handle as well. We are recording the session as well, so a recording of the webinar will also be posted. Okay, great. So the next question from Amanda asked, how do you incorporate quality of the clinical evidence, ROB, grade, etc., into the economic model? Does this appraisal actually feed into the model, or is poor quality clinical evidence, for example, simply identified as an area of uncertainty?
I mean, I can briefly speak to that. I think sort of within our work, one of the key considerations that we have is the quality of evidence surrounding the treatment effect of the intervention. And that's what our review is done around. And if at a certain point we, following the critical appraisal, we find that that is not, the quality of the evidence is poor, we actually stop the HTA. So we do not proceed with conducting a full HTA. So our focus within our work is to really assess the quality of evidence around the treatment effect of the intervention. So we cannot rely on the evidence that says that the intervention under evaluation is effective and we can trust the evidence. We do not proceed with full HTA. But so I hope that answers the question.
I can a little bit of a comment.
Yeah.
So, for example, if the quality of evidence is somewhat low but acceptable in by the say policymaker, then the modeler, so low quality of evidence, then it means that if future evidence is available, then the estimate is very likely to change. And so then, because of that fact, then a modeler could do something in the design of the model to accommodate future change if a new evidence is available. But then that structure will have to put in when they design the model, so that's important for them. And secondly, for example, if there's we found that there's a high risk of performance bias that the patient knows about their intervention, and therefore might likely that information might change some outcome, then we can choose, we can help the modeler to choose an outcome. For example, all-cause mortality is less likely to be influenced by performance bias. Then that all-cause mortality might be the driving treatment effects of that model, which will also help mitigate the risk of performance bias. So these are all these things that we can do in modeling if we know what risks are we facing. So that might be a scenario. Tanya?
And just to complement, yes, if the evidence is still acceptable to proceed with conducting a modeling analysis, we do use to identify areas of uncertainty where you make the model probabilistic in certain parameters, because often and sometimes not all model parameters can be probabilistic, or sometimes it's not appropriate to be probabilistic because you lose correlation. So when you're model planning for your design, those areas where you have lower quality of evidence, or you wanted to explore the uncertainty on those parameters, then you can plan for probabilistic analysis or sensitivity analysis or scenario analysis that will tackle that uncertainty around the parameter.
Great, thanks. Man Manhua also shared a comment in the chat on the question in regards to additional resources beyond the JBI guidance, sharing that the NICE guidance manual has it might be an informative resource. So the link and some details is there in the chat for anybody who might be interested. We have a couple of questions here that actually I think we can kind of merge together because they are similar. So one is asking if you could speak further about how you set up your team at VCHRI. For example, the number of health economists in total, the number of staff per project, usual timelines. And then we also had a question, similar question about how many people do you usually need to complete an economic model?
Megan, do you want to jump in and tackle that?
Yeah, for sure. I actually, just wanted to go back briefly to a comment Andrea made, and that was great to highlight the JBI, the checklist. And I think maybe Tanya and Pardis would agree with this, that there's obviously what's published, and you can go from the actual published article, but I think ultimately you have to get under the hood, so to speak, into the engine of the model to start really digging around to understand, because all of it can't be published, like what's informing those transitions. Where's the data coming from for each of the, for example, the Kaplan-Meier survival curves that are informing each of the different areas within the model. So I think there's just a lot of complexity there. And if anyone has ever read through maybe, our report, if you've been, to the BC Ministry website, or even a CADIS report or HQO, you get a sense of that by going through sort of the appendices labeled into the double and triple digits of the alphabet. So just wanted to point that out. The checklists are great, but sometimes you really have to get under the hood to really understand what's going on in those models.
Can I just compliment what Megan's saying here? Sometimes it's not even the checklist. Like, you really need to think critically about the assumptions of the model. Like, do they make sense clinically? And that's why you need some sort of content knowledge to know if that modeling assumption makes sense clinically to be represented mathematically. So you do need to get down to the details. The devil is in the details in this type of work.
Yeah, and to add just the local context that we're looking at as well. So it becomes quite complicated very quickly, because the specific, as I mentioned, that sort of that initial decision problem is not necessarily translatable across what we are doing all the time as well.
Thanks both. And then just quickly, I see we have like probably less than 60 seconds. How do we form a team like this? Well, you know, Tanya and Pardis and Craig are the original members of the band, so to speak. And so then we grew a little bit with Pardis, who has health economics training. So Pardis and Tanya, both health economists with health economics training, can actually program the model. Gavin is trained as a systematic reviewer, his PhD work, and also we're lucky he also has clinical training as a respiratory therapist. We also have a patient engagement lead, that's Neil Smith, and he is not here. And then within our team, we actually conduct those stakeholder interviews with the clinicians ourselves. And then I think it's really important to mention as well that we are very fortunate to work with excellent information specialists who help to develop the search strategies that inform the treatment effect, where the systematic review that Gavin is talking about, the evidence review, and as well capturing the health economics literature there. So that is also done with those colleagues. So it's a broad team, and it takes a broad team with this diverse skill set to be able to address all of the issues that our Ministry of Health at least have raised in terms of evaluating technologies and determining whether or not they will be publicly provided or whether disinvestment is needed.
And we put out about 5 or 6 HTAs ourselves, and then that's why the other groups are involved in the BC work as well, because the BC Ministry has typically 10 to 15 a year that they are contracting out. So.
Great. Okay. Well, I think that brings us to the end of today's webinar. I'd just like to thank again all of our great speakers. I think, judging from the number and quality of questions, obviously there was a lot of interest in this question, and some great things to consider. So thanks again for a great presentation. As I mentioned before, we will be sharing a recording from this session, as well as the slides on the COVIDend website, and we'll also share those out through our Twitter handle as well once they're posted. So thanks again, everybody, for joining, and we hope that you'll join us for some of our future COVIDend webinars as well. Thanks again.
Thanks, everyone. Bye for now.
Bye.